Nasal fibers of the optic nerve will cross the opposite side. Temporal fibers won't cross. Complete loss of vision in one eye is anopia. Half of the field loss is hemianopia. Suppose left side nasal loss is there, it is left nasal hemianopia. Temporal field loss in both eyes is bitemporal hemianopia. Left side temporal loss with right side nasal loss is left homonymous hemianopia. Right side temporal loss with left side nasal loss is right homonymous hemianopia. Superior quadrantopia is pie in the roof, inferior quadrantopia is pie in the floor, and homonymous hemianopia with macular sparing is lesion 7. 58-year male having hypertension had weakness of left upper limb and lower limb associated with giddiness and speech disturbances, was admitted and found to have diagnosis of right posterior circulation stroke, in which thalamus and posterior cerebellum also involved, and field is showing his left eye temporal field is lost, so left homonymous hemianopia.
दिखा आप बोलना हाँ दिख रहा है, ठीक है। आप मुझे सीधा देखना, इधर मत देखना। मेरे को अभी तक दिखने लग गया है। Again, the examiner have already started seeing it, but the patient is yet to identify. Now the patient identifies. Let us test the nasal quadrant. Let us test the nasal quadrant. We tested the temporal quadrant of the right eye, and the examiner was able to identify, but the patient was not able to identify this quadrant till the finger was here somewhere. He said yes, but the finger was way back, identified by the examiner. Now let us examine the nasal half of the right eye, the nasal quadrant of the right eye. मुझे देखते रहिए, हाँ? हिलता हुआ उंगली दिखा तो बताना. Yes. Simultaneously, the examiner and the patient are identified. Yes. Yes. So the nasal quadrant of the right eye is normal, but the temporal half is abnormal. अभी ये आँख बंद करेंगे, हैं? मुझे देखिए. Yes, normal. Both are identifying at the same time. Yes. बढ़िया. The temporal half of the left is normal. Left eye is normal. अब मैं इधर से हाथ लाऊंगा, इधर देखते रहिए. I am already able to identify the patient is identifying now. I am seeing it here, yet the patient is not saying anything. Now the patient is identifying. I am identifying now, patient is yet to say something. Now. Okay. So after confrontation test, we saw that in this patient, first we demonstrated threat reflex. When we demonstrated threat reflex, what was the clinical finding? When I was bringing my hand from here, there was no blinking. But when I was bringing my hand from the temporal half of the left eye, there was blinking. That means something is wrong in this field, temporal half of this visual field. When we went for the confrontation test, we confirmed that in the right eye, the temporal half was abnormal, and the left eye, the nasal quadrant was abnormal. So this is a type of homonymous.
Now look for hemianopic defects, which are defined as having defect borders aligned to the vertical meridian of the visual field. Decide if a hemianopic defect is present in the temporal visual fields of both eyes, a so-called bitemporal hemianopia, which is the signature of a chiasmal area lesion. Besides the classic bitemporal hemianopia, there are two other visual field patterns of chiasmal area lesions. First, there is the unilateral temporal hemianopia in one eye and a normal visual field in the other eye. This combination spells a lesion in front of the chiasm in the intracranial part of the ipsilateral optic nerve. Then there is the temporal hemianopia in the field of one eye and a nerve fiber bundle defect in the other eye. This hybrid pattern of hemianopic defect and nerve fiber bundle defect spells a lesion at the junction of the optic nerve and optic chiasm. If the clusters of high threshold points lie on the same side of visual space in both eyes and have borders aligned to the vertical meridian, you will be diagnosing a homonymous hemianopia. This pattern is the signature of a retrochiasmal lesion lying somewhere between the optic tract and the visual cortex. A complete homonymous hemianopia, such as you see here, does not allow you to decide where within the retrochiasmal visual pathway the lesion lies. On the other hand, an incomplete homonymous hemianopia permits you to refine your localization. You will do that by looking for one of the following 11 patterns that localize retrochiasmal lesions. Number 1. This is an incongruous homonymous hemianopia defined by the fact that the defects in the two visual fields are not of the same size and shape. This pattern localizes the lesion to the optic tract. Many lesions occur there, especially masses and inflammation. Number 2. This is a congruous homonymous hemianopia. It is defined by the fact that the defects in the two visual fields are of the same size and depth. This pattern localizes the lesion to the far posterior optic radiations or visual cortex. Many lesions occur here, especially strokes and tumors. Number 3. These are pie-in-the-sky defects. They have one border aligned to the vertical meridian and the other border extending radially into the superior visual field. This pattern localizes the lesion to Meyer's loop in the anterior temporal lobe. The most common cause of these defects is a temporal lobectomy for intractable epilepsy. Number 4. This is a superior homonymous quadrantinopia. It is defined by the fact that the defect borders are aligned to the vertical and horizontal meridians in the superior visual field. This pattern localizes the lesion to the inferior visual cortex. The most common cause of these defects is stroke. Number 5. This is an inferior homonymous quadrantinopia. It is defined by the fact that the defect borders are aligned to the vertical and horizontal meridians in the inferior visual field. This pattern localizes to the superior visual cortex. The most common cause of these defects is stroke. Number 6. These are homonymous paracentral scotomas. They are defined as hemianopic defects restricted to the central degrees of the visual field. This pattern localizes to the far posterior visual cortex, and the most common cause is stroke. Number 7. This is macular-sparing homonymous hemianopia. It is defined as hemianopic defects that spare the central 5 to 10 degrees of the visual field. This pattern localizes the lesion to the anterior visual cortex, and the most common cause of these defects is again stroke. Number 8. This is a temporal crescent defect. It is defined as a monocular defect that involves only the peripheral crescent of the temporal field. This pattern localizes the lesion to the far anterior visual cortex. This is a rare defect and is probably most often caused by stroke. Number 9. This is a temporal crescent-sparing homonymous hemianopia. It is defined as a homonymous hemianopia that spares the peripheral crescent of the temporal field. This pattern indicates that the lesion did not damage the anterior visual cortex. The most common cause, again, is stroke. Number 10. This is the hourglass homonymous hemianopia characteristic of a stroke of the lateral geniculate body caused by occlusion of the anterior choroidal artery. This defect is rare. Number 11. This defect is the silhouette of the hourglass homonymous hemianopia. It is also characteristic of a lateral geniculate body stroke, this time caused by occlusion of the lateral posterior choroidal artery. This defect is also very rare.
Here is pituitary adenoma causing compression of chiasma, which cause bitemporal hemianopia. Here pie in the floor is due to stroke in the occipital cortex, that is superior occipital cortex. Thank you.